Yeah, that's cool. All right, you guys want to get started? Sure.
All right, we are going to get started and, entertain ourselves if people join. So I'm Danielle Miller. I'm an assistant professor at the University of Colorado. I'm here today with my team talking about physical and biophysical markers of assessment in CBME. I'm here with Dr. Breivik. He's our medical education fellow, Dr. Michael, fellowship director, and then we have our collaborators here today. Or they're not here today, but yeah. We have no financial disclosures. We will discuss novel technologies. We're not funded from any of those, and then images are just representative and not endorsements. And so our learning objective is sort of by the end of this 50-minute didactic, we'll be able to describe 8 physical and biophysical markers of assessment and the technology they use, describe the current use of physical and biophysical markers in assessing your knowledge, your skills, your attitudes of trainees. We're just going to discuss the pros and cons of incorporating technology and sort of cite examples for future use. And the way we kind of came into this topic area is just our team is very interested in this Venn diagram of where technology and assessment come together and sort of what's out there. So we conducted this large scoping review over 463 articles, and where we sort of looked at these technologies. We're talking about heart rate variability, visual attention, fMRI, fNIRS, salivary cortisol, hand motion, and sort of asked how are they being used to assess our trainees, and what could their use be? And so this is sort of a distillation of all the technology and all the potential uses. I think I have one more. I do. So as an introduction, we know that assessment methods have been this area of innovation recently. CBME requires us when we're making assessments to be outcomes oriented, learner centric. Emphasis on trajectory and timing is usually de-emphasized. We just want to get you to competency. And when I think about assessment methods, I think about what we're currently using are written assessments. Those are your MCQs, short essays, and more often in graduate medical education, your observational assessments. So that's your 360-degree feedback, your OSCEs, et cetera. But some have argued that assessments kind of need to change. We have an evolving skill set that physicians are now required to do, and maybe these technologies can give us can augment the assessment or facilitate assessments. So what technology are we talking about? We're talking about is there a new way to measure what a learner is thinking or doing? So for instance, what are their hands doing? What are their eyes doing? What is their brain doing? And is that different than an expert? And so we're asking can these technologies give us insight into what the learner is learning or has already learned?
If you went to the keynote yesterday that Dr. Coretta Wire gave, she talked about pointillism and George Seurat and about how all of these different pieces of information, all these different dots make a picture.
Yeah. Mm-hmm.
We came up with a slightly different analogy. We imagined these 9 squares as part of a Rubik's Cube of knowledge and skills and attitudes, and we can look at one face of them with the assessments that we currently employ, but they don't really tell you anything about the sides or the bottom or the top or the back of the Rubik's Cube, except that you've already demonstrated these 9 things. And so we're not talking about replacing our current assessments, our OSCEs, our direct observation, the oral board examinations that we're using. We're talking about, is there something out there that can help us get a little bit more data to paint a clearer picture when we're making assessments about competency or promotion? We're going to start transitioning into the particular technologies that we're talking about. I think this is the one that's going to be most comfortable to us because we all know what heart rate is. We have a sense of heart rate, and we know what tends to make our hearts pump really fast and what makes our patients' hearts pump really fast, right? We understand the influence of the sympathetic nervous system, and we know that when we get really anxious, our heart rates go up, and when we're cool, calm, and collected, they tend to be a little bit lower. One thing that we don't talk as much about, but is becoming pretty trendy, is heart rate variability. Heart rate variability is the time between different heartbeats in the same individual, what we see is that when people are well rested, well recovered, not acutely stressed out, their heart rate variability tends to be pretty high. This makes sense because of the input of parasympathetic tone. We know that when people take a big deep breath, right, slightly increased distance between each R-to-R interval. And when we see that typically in ourselves and our patients, and we can actually use this data to say what someone's acute stress might look like. So one of the things that we have seen in the review that we did was the utilization of heart rate variability for the assessment of non-technical skill to assess acute or chronic stress management or detection. One example of this is a study of people who were learning to do colonoscopies. And we saw that there was greater stress during the moments leading up to the beginning of the procedure, the start of the procedure, and then once the procedure was underway, the trainees actually calmed down and did better. But maybe there's an opportunity from a coaching perspective to help people do that first part more effectively. We also saw heart rate variability as a reflection of attitudinal skill and well-being. Right, so we know that if we're poorly slept, poorly recovered, our heart rate variability is going to be a little bit lower. That potentially has implications for scheduling and general sense of burnout among trainees. This is a study of emergency medicine residents and attendings, and they looked at a variety of factors, including heart rate variability, skin cortisol, skin conductivity and salivary cortisol, which are factors we're going to talk about in a little while, and then compared that to burnout using the Maslach burnout inventory, and saw that while residents and attendings had similar levels of burnout, they experienced different levels of acute stress and cognitive load on their shifts, which makes sense, right? And it might mean that as we experience less cognitive load and have improved heart rate variability on our shifts, that we're actually coming into our own and we're comfortable in our environment, and that could be a reflection of the development of expertise. We'll transition now to visual attention and gaze tracking. This is an image of the pupil neon glasses. Gaze tracking comes in kind of two flavors. There's screen mounted and head mounted. So what we've got here is head mounted. Screen mounted fits on the top of the computer screen, and it's able to see in real time in both cases what the person who's doing the viewing is looking at in real time. It also calculates their saccades. So when you look at something, you're not just looking at one thing, you're bouncing your eyes across the room, looking at different things, and you're using that information to make decisions about something. And this is basically capturing all of that information. We have some limitations of this technology. It's very expensive. Glasses like these cost at least $10,000. The computer-mounted stuff is a little bit less expensive in the couple $1,000 kind of category. It requires calibration, particularly with the older models. Newer models actually use an AI model to calibrate, and so they don't have the same kind of technical drawbacks. Using these in a really dynamic situation can be a little bit tricky, because if you're moving between places, coding things in terms of what people are looking at in real time can be a little bit challenging. But there are lots of studies looking at visual attention on a computer screen, EKG interpretation, pathology interpretation, imaging interpretation, all of which is really ripe for that. These glasses have interchangeable lenses in many of the models that can accommodate -3 to +3 prescriptions, and they are compatible with contact lenses, but they don't necessarily calibrate super well for really severe myopes and people that fall outside those prescription categories. And so they're sort of limited in utility. You could not require an assessment like this of all of your residents per se from an accessibility issue. We see visual attention and gaze tracking used for assessment of knowledge with the regard to the interpretation of some of the stuff that I talked about earlier, imaging, pathology slides, other clinical media. Where are your eyes looking? You know, when I was a medical student, I was taught to look at EKGs in a really systematic way, and I would say as an attending, I do that a little bit less, and I'm more sort of scanning a global picture. And as we see that transition from the very precise, intentional observation of trainees? Do we see something different with experts? So here's an example of that. This is a study by Wu et al. In emergency medicine. And we're looking at the delta between the patterns seen in novices versus those demonstrated by experts to try to assess when that transition to expertise occurs. We also see this technology used in the assessment of technical skills, which you might imagine, because we can see what people are looking at in real time as they're doing a procedure. This is an example from the surgical literature, comparing the gaze of attending surgeons to that of resident surgeons with regard to cholecystectomy. We can also use visual attention for evaluation of leadership. What is a resuscitation leader looking at in real time? Are they fixated on the particular injury? Are they fixated on the patient's face? Or are they looking at a little bit of everything and doing a good job showing attention to their team members, receiving information? This is a study that's an example of that. That is a postpartum hemorrhage scenario, where in many cases, the team leader who was situated at the head of the bed was overly fixated on the umbilical cannulization procedure that was happening and not focused on the infant's vital signs. We can use really similar technology to do pupillometry. So I'll talk about it here. This is the Tobii Pro lens setup. Again, same kind of expense related to the technology. You also see this kind of technology in your car. So if you drive a car that alerts at you when you start to drift off to sleep a little bit, maybe after a night shift, it's using this same technology. So it is having cameras that point at you, that are looking at your pupils, measuring dilatation and position of the lid with regard to the pupil and blink rate. So that's what this technology can do, and we often see overlap in hardware, but the analysis is really different and the types of things that it can tell us about a potential learner are really different. We see pupillometry used for the assessment of technical skills related to surgical procedures. So the idea here is that when you're looking at something and it's really stressful or you're cognitively overloaded, you'll have some pupillary dilatation as part of a sympathetic response. And in that case, you can see when learners are encountering a surgical difficulty or a procedural complication that they actually do demonstrate that response. We also see it to evaluate cognitive load. That makes sense, right? When you're sort of overwhelmed with information and things are really difficult, you'll have a pupillary response associated with that. This was a study where they actually used it to assess some knowledge, and they gave students a clinical scenario, different levels of difficulty, and saw the response of the learners compared to the response of the experts. So the experts were like, yeah, this is not very difficult. They don't experience much pupillary dilatation. The novices do. We're going to transition to hand motion analysis.
I think you were going to do that, but I can do it if needed. Oh, okay.
So hand motion analysis, essentially it's using like electromagnetic sensors attached to the subject's hands or instruments to measure their position in space and movements relevant to a magnetic field generator. Sort of as proficiency in a technical skill improves, the training and or time, these measurements should sort of reflect your economy of motion and better economy of motion. And so this can be used, obviously, and it's only used in technical skills. So like how people are using ultrasound in surgical procedures, and how does that compare to like an expert? And so this one, use of hand motion analysis to assess competence and skill today for cardiac and lung point of care ultrasound, where they were looking at novices and experts using an ultrasound, performing a fast exam, and essentially showing, you know, experts have a lot more economy of motion than the novices. And maybe based off of that data, you could do some coaching for the novices to help them bring them up to expert level. All right, we have 4 more technologies we're going to discuss. This is functional magnetic resonance imaging. We're all pretty much familiar with this. Essentially, it's an indirect way of measuring electrical activity by detecting how oxygen is flowing through the brain, and you calculate a BOLD response, BOLD, blood oxygen level dependence, and then that's like converted into these different kind of color. The interesting thing about fMRI is it's had like a wide use of applications in studying like learners or assessing learners' knowledge, skills, and attitudes. So I'm going to go through a few studies. So knowledge, this makes sense. Like you can put people in a functional MRI machine and figure out sort of clinical decision making. And so, for instance, in this study, they took medical students, and this is a functional neuroimaging study of clinical reasoning of medical students, and they basically gave them these like routine, like easy questions, like, I don't know, what is a normal hemoglobin count? I don't know, they give you a range, versus these complex questions on clinical decision making, put them in an fMRI machine, and sort of said, what are their brains doing? And so the authors in this paper make the argument that like, hey, like we only understand clinical decision making from us observing them, but would it be interesting to see what the brain is actually doing so we could optimize teaching? And in essentially what they found was obviously there are like really quick pathways for these recall questions, and then it is much more burdensome on their brains to do these in certain centers of the brain for doing these complex clinical decisions. And so you could imagine like a future study could be like, okay, so like maybe we coach them how to like do these clinical decision makings and these specific different curricula, and like which one's actually getting them to like the brain, the brain areas where there's like less burden and kind of functioning. Again, fMRI has actually been used in technical skills, so surgical skill assessment. So this is assessment of competence in surgical skills using an fMRI, a feasibility study. So in this study, again, they wanted to find the neural pathways of like what's going on with surgeons when they're doing their routine skills. And so they sat both novices and expert surgeons in an fMRI machine and had them do knot tying. Of course, the surgeons the expert surgeons had very little brain activity when they're tying knots. Like this is just a routine performance for them, versus a lot of the novices had certain areas of the brain that were firing, including some emotional centers. And so it kind of gives us into insight on like what's going on between novice and experts. It's a feasibility study because they also wanted to know like, can you do movement in an fMRI machine and still get data? And like in terms of them just sitting and doing some knot tying, there wasn't a bunch of motion artifact that decayed anything. It also helped with non-technical skills, so communication. This was interesting. So this was a study on effective doctor-patient communication skills. Training optimizes functional organization or intrinsic brain architecture, a resting state fMRI study. So in this study, they took medical students. They did a baseline fMRI of them communicating with a patient. Or like a SIM patient, like how they would communicate some information. They put them through a workshop, had them go out in the clinical environment, did another fMRI, and then a year later, after they've been practicing this clinically for a year, did another fMRI, and they found that these communication centers showed more plasticity than at their baseline. What I think could be interesting about this is like, what if you find some sort of like expert communicator and you're like, well, what is their brain doing? And then what curriculum could we potentially get them to do that sort of, get them to that brain kind of state? And then lastly, very interesting, empathy. So this was fMRIs have been used to like figure out empathy in students. So this is different than is an empathy towards patients between medical and non-medical students, an fMRI study. So in these studies, they took medical students and non-medical students, put them in an fMRI machine, showed them, had them read through cases of patients like in pain, and had them be both role play the patient themselves and the provider. And of course, medical students, they were measured less at the empathy kind of areas in the brain were like kind of less empathic. we can all hypothesize why that is. Like, potentially this is a way that you actually can function and do your job. Or maybe actually we need to do some more resiliency training and build those centers up. Regardless, these are all like very small pilot studies and sort of like, is this feasible? What information is it giving? Pros and cons of fMRI, as you can probably tell, is like you're in an fMRI machine, so like you can only do so much in there. The cost, like none of these papers gave like the cost of their project, which is unfathomable to me. So like the best proxy, and I don't even think this is a good proxy, was like if you're like an insured patient, right? Like an fMRI is $500 to $700, and so imagine if what you're doing when this is outside of an insurance. Again, a lot of these studies are small, less than 20 trainees in general. And then lastly, again, besides the expense, it's not portable. And so how are you getting your trainees to come and do this extra fMRI study? And very similar, but slightly different, functional near-infrared spectroscopy has had some interesting applications in assessment of our trainees. So again, this also evaluates blood oxygen levels, but essentially does that through light measurements based off these sensors on the brain, so what light is absorbed. Again, this has some interesting applications that are similar to fMRI. So technical skills, similarly, you can measure like what's the brain doing during certain procedures. So this is the use of prefrontal cortex activity as a measure of a learning curve in surgical novices, results of a single blinded randomized control trial. So essentially similar to the previous, you're just saying what are novices' brains doing during surgical activities. The other finding of this study that I just want to quickly mention is this also incorporated a component of like a workshop, and they found that certain learners responded much better. Their brain activity was essentially less chaotic when they were just given a formal workshop, but other learners, like, they actually did better with just some like independent, like let us do some laparoscopic surgical skills. So this had some interesting just implications of them saying like, this might be precision medicine and coaching. Like some people might need to just do some independent, like get thrown into an area where they're doing laparoscopic simulation, and that's how they're gonna learn. And other people want some more formal like workshops. Again, fNIRS has been used for kind of testing or assessing decision making. I love this paper, Contemplating the Next Maneuver, great title. Functional neuroimaging reveals interoperative decision making strategies. So they had these fNIRS on both residents and then attending physicians. They were not in the operating room, but they were shown videos of a straightforward cholecystectomy, and at certain points in the video, they were asked, what is the next step of this procedure? And so what happened was, in some of the instances, the surgeons were, quote, primed, so they would show them something that would indicate what the next step was, whether that's like an instrument or a move that they would do, and other times they were unprimed, so they're just like, what's the next step? The experts had zero, like their brain activity was like very consolidated, and essentially whether they were primed or unprimed, very easy, brain activity similar, versus the novices, again, they responded better to when they were primed. It kind of gives you this idea of like, this is why we supervise, right? Like, and maybe someone needs to be primed early, and later a teaching strategy to get them to the next level is to be kind of unprimed. And so this was, again, a feasibility study, but some interesting findings. Lastly, we talk about like non-technical, or I guess there's two more, non-technical skills, cognitive load and stress management. So this was using fNIRS, to essentially examine team experience during crisis management, right? So this whole anesthesia team, they all had different roles. They wore these fNIRS. They went under a stressful simulation, and they sort of just mapped like who at different points during this encounter are experiencing more cognitive load and brain activity than anyone else. And you can imagine that gives us insight into like, well, maybe these stressful events and certain people and their roles at certain times, they're gonna have increased load, and that might be an area that's prone to error. And so you can imagine doing a curriculum to sort of address these variances in roles. And then lastly, similarly to the fMRI study, they've used fNIRS to talk about like empathy and sort of assess empathy. And similarly, this was a study on the influence of medical professional knowledge on empathy of pain. Very similar to fMRI's study, students and medical students and non-medical students were shown images of patients in pain. Medical students had kind of less activity in the correlate areas of the brain where empathy is usually measured. All right, 2 more, but I'm going to hand it off to Dr. Breivik.
All right, so salivary cortisol, this is pretty straightforward compared to all the fun technology we've been talking about. So in high stress situations, we expect cortisol increases, and so you can take salivary or serum cortisol. Serum cortisol takes a lot longer to rise. Salivary cortisol is a lot easier. You can have someone spit into a tube, and then it's measured and assessed by ELISA methods. This is an expensive and time-consuming process for a relatively simple adjunct for performance, stress, and reaction. So the majority of the studies that use salivary cortisol use it to assess more of the non-technical skills components, the arousal management, the amount of sympathetic tone that people are experiencing. So one of the studies that I thought was really cool, talking about that cognitive load stress management, was this appraisal of stress and responses in these simulated trauma resuscitations. So they took individuals and put them in these high and low stress pre-done situations and simulations that were designed to be similar to typical trauma resuscitations, and then measured their salivary cortisol levels. And we can all guess what happened when your salivary cortisol levels are measured during different stressful situations. So it's whether or not this is actually, oops, I slid the wrong thing, sorry guys. It's whether or not this actually has any bearing or impact on the ability of us to actually determine whether this is something useful to intervene upon. So in our more inexperienced populations, do they have a higher level of cortisol? Does that mean they have lower abilities to manage arousal? Or is this something that we could say, as they get more expert, is this a lower level? But the difficulty with salivary cortisol is there's a minimum concentration at which the measurement actually becomes a positive value. And there's an argument to be made in a lot of the studies that says, well, if you hit this measurement at all, are you having extraneous amounts of excretion, right? So then after that, it's kind of like a binary plus minus, right? If your D-dimer's positive, it's positive kind of thing. So the value is a little bit more limited there. There was another study that I found a little bit more useful, which is correlating this to your resiliency, your grit, your ability to deal with burnout. And so they took post-shift salivary cortisol levels from a group at an academic ED where they had residents and attendings, and they took all these samples for actually a few weeks at a time, and they did it in different times of the year for the different studies, portions and stages. And so they looked at it, and there was actually no comparison that showed that there was an association to grit with the amount of cortisol and post-shift amounts. But the funny thing is the way they measured grit was this very subjective survey set. So I don't know, we all have a hard time identifying what does grit actually mean. I think it was more useful for the self-perception of psychological well-being and their cognitive assessment of their ability to deal with high-stress situations and how they appraised those. And so those who said, well, I had a really, really stressful shift today, was it correlated to their level of cortisol? For attendings, it was not, and for the residents, it was. So there's a little bit of a balance there. Skin conductivity, it's very similar, also similarly simple. Actually, I will say, going back, the cost of the salivary cortisol it's really expensive. It's like $400 per sample per person, although you can batch them and get it as low as like $50. But to get these studies to be effective, you have to do large volumes of these over time. So not necessarily as helpful given the cost to the benefit. But skin conductivity. So this is really kind of cool. It actually measures the conductance of electrical impulses across the skin from different points in the body, and it's an adjunct for assessing your sympathetic stimulation. And so it's very similar to the salivary cortisol in that it's a measurement of heightened arousal. Something interesting about this one is that you can do it pretty much at any time during a clinical shift, during a simulation, during case-based discussions. And so you can just have these things that are pretty imperceptible once you've had them on for a while, then you kind of forget that they're there. So it kind of helps take away that, oh, I'm being monitored bias. It's a pretty useful thing to add into the mix. So the study that I thought was very interesting was this, there was a diagnostic reasoning simulation where they put these medical students and early residents through these series of different increasing complexity, complicated testing scenarios. They said, here's this clinical situation, here is whatever, I want you to reason through this EKG, things like that, and then had them measure those sympathetic impulses through the skin conductivity, and as expected, at lower levels of training, they have increased sympathetic firing, almost to the point where the noise is so much you can't really dissociate it from the acute arousal state. Whereas in more early clinicians and more experienced clinicians, you can very clearly identify the areas where they have pretty significant increases in skin conductivity. Most of these studies also included the heart rate and heart rate variation, and so they used multiple different measurement points, although this one they primarily cared about that skin conductivity. And, oh yeah, mine are fast.
Yeah, so we did it. We made it. We talked about 8 physical and biophysical markers. We talked about the technology that sort of goes into these markers, and then potential applications for our learners in assessing knowledge, skills, attitudes. Again, we talked a little bit about pearls and pitfalls, cost, to sort of give you an overview of like what is sort of on the horizon next for these technologies.
We would say that the take-home point here is not that you should rush out and spend $100,000 of your department's money buying all sorts of fancy toys. But really, we just wanted to introduce some things that have been on the horizon that people are using and talking about in medical education assessment, and kind of make sure that you leave here today or review it online as a webinar. And so that you have some background information about these when you see articles come out about them, because there actually are a fair number of these articles in the education science literature, and we should be able to know what they are when we see these terms used.
Perfect. And these are our references. We're open to any questions, and thank you all for attending. Yeah.
Have any of you implemented some of these technologies so far? What has your experience been like?
That's a really good question. I have a couple studies with these technologies. We have one study that's currently paused at the moment of a visual attention study of residents leading trauma resuscitation. So we have a pair of these older school visual attention glasses and can put them on people and can code what they're looking at in real time with the goal of trying to identify patterns that might be unique to a particular individual or represent different groups of individuals over the continuum of training. There have been some technological barriers associated with that, just with regard to the glasses connecting to an iPad, and some, I would say, learner reluctance to don additional hardware as they're thinking about also starting to lead a trauma resuscitation. There are some studies in emergency medicine of simulations that use that technology. There's pretty good evidence that the visual attention patterns seen in simulation is pretty different from the real clinical experience and might not be a valid assessment tool of what someone's doing in real life. So we're still thinking about that, trying to overcome those problems. I'm involved with another study that uses heart rate variability and associated movement analysis using the wearable polar chest strap that we saw in the first slide. And that study shows increased cognitive load as evidenced by decreased heart rate variability during high stress aspects of critical care transport simulations.
And then one of our other collaborators who's not here today has done the hand motion studies. He was involved in that ultrasound study, Dr. John Kendall. And that's interesting because again, similarly, the technology in some respects is easy. You put on the wires on the hand, but it's sometimes challenging to set it up because you have to have it in a certain spot and they're measuring distances. I think the technology is only going to get better and it'll get easier, but it is learning a whole new software. It's like when you get a new computer or iPad, but much more difficult. We've all gone through those growing pains with those. But yeah, I think largely like our interest is just in could these technologies aid in human performance, and sort of the reason we did this big deep dive into the literature, and we have a scoping review coming out in Medical Teacher on all this in a month or two. Was just to be like, should we invest in other technologies, right? Like, we haven't invested in fNIRS. Like, is the $20,000 to $50,000 worth it? I don't know. So I think having this information out there helps other education researchers make some sort of sense of like, what would this help us assess in general, and like, is it worth our investment at this time?
Cool.
Sorry about the small group.
Yeah.
Among us chickens, I'll point out something that I saw on the author that seems like there's this geographic clustering around technology. I get that some of that probably is just like developed expertise around some technology. But 10 years, it looked like it was almost exclusively stuff out of like Singapore, or wait, is that right? Is there like a
Yeah, so we can pull the numbers. When we did like the big scoping review, the United States like had done most of these studies, but then most of these studies are heart rate. The fMRI and fNIRS, there's like 2 or 3 authors that are like doing this, right? They've like obtained the somehow have gotten that funded. But yeah, you're right. It's like when you get into like the more expensive, like the fNIRS, fMRI, there's like a handful of authors that are just kind of doing all the studies. Ooh, that's a good question. We'll do some investigative journalism, Sean, okay?
And I think to that point, right, does that provide homogeneity in the types of studies that come out, right? Because if it's the same 3 authors writing all the papers on the same topic, is it really that valuable, or is it just, we hope for impartiality, but you're right, it's interesting.
Cool. Any other questions? Awesome. Thank you all.